Hawaii, so they think in terms of a leaky boat, but it's the same concept. And the other one is that, and this I think is really helpful to clinicians, because some people who are fairly far from the threshold and appear safe, so you're not really worried about them, you're not trying to bring them back early for their next visit, those folks are actually at risk of slipping out of control. Now, it's a minority of those folks, so the question is, can we develop a predictive model that'll help us find them? So, the builds seem to be working automatically. So we can just show you what happens. We have a partnership with Optum and our members who are using Optum population health analytics tools. And so we have access to the detailed patient level data for about 30 million patients. And we're able to follow what's happening to those folks over time. So this is how we kind of got into the idea. Is looking back in 2013 as we were beginning our planning for Together to Goal, we were thinking, well, let's follow what happens to the 22% of people whose A1C is 8 or greater, which was the campaign threshold that we were contemplating, and the 78% whose A1C is less than 8. And then let's follow them over time. And as you can see, people move in and out of control. And you wind up at the end of 3 years, and this is about 500,000 patients, not quite 500,000, who were measured in each of 3 years. You wind up with 26% of patients transitioning, which seems like a very large number. So that's the reason we started looking at this. And here when we start with a smaller group of patients, about 250,000 patients, but what we're looking at here is people who have their A1C measured at a baseline point and then again 12 to 15 months later. So we can sort of quantify what happens over this year or a little longer than that. So we start out with 23% of patients whose A1C is 8 or greater and 77% whose A1C is in control. So 12 to 15 months later, we wind up with about 13.6% of the population out of that original 23% who stayed out of control and 9.6 who moved into control. But the leaky bucket phenomenon is that simultaneously 8.5% of the total population, people who were in control before, have slipped out of control. So you wind up at the end with, instead of 23 and 77%, you wind up with 22 and 78%. So you have a net improvement of only 1% after doing all the work to bring 9.6% into control. So that's what we think of as the leaky bucket. And we're able to look across our members who are using these Optum population health analytics tools, and this is an amazingly consistent phenomenon across every one of the groups. The numbers may be a little different, but the delta, about 1%, is pretty consistent. And so that got us thinking, well, you know, this is probably a lot of people who are very close to the 8 threshold, either right below it or right above it, and they're just moving across the threshold. So then we started looking at a distribution of all of the people who are the changes in the A1C over that 12 to 15 month period. And as you can see, the center here is obviously a change of 0, and most people have a relatively small change, and many of them stay in control. Those are the ones who are green. A few stay out of control. Those are the ones who are brown. But the interesting part is how big the change is in A1C for the people who move from, and there are a few who are right at the border and moving by just a little bit to get into the other category. But on average, it's the people who are slipping out of control, it's a 1.6 absolute increase in A1C. And for the people who are coming into control, it's a 1.8 average decrease. So what we were thinking about is, well, let's look at this from the population perspective. And the blue bars up at the top are the number of people who are in each of the ranges from 4 to 4.9, 5 to 5.9. So the ranges are in the middle there. and the proportion of patients in the population are up on top. So you've got about 39% of your patients who are 6 to 6.9, 13% who are in the 5 to 5.9. So what we see, obviously, is the people who were over 8 to start, who are 8 or over to start with, they are either staying out of control, which means they stay in the brown color, or half of them who are between 8 and 8.9 actually do move into control. They move under 8. And then about a third who are between 9 and 9.9 move into control, and maybe a quarter of the other smaller populations with higher A1Cs are actually moved into control. But then you can see that these larger populations of people who are in control to start with, 24% between 7 and 7.9 are going to be out of control. The interesting part, we thought, was the folks who are between, say, 5.5 and 6.9. Those are the ones that you probably think are safe because they're at least a full % away from your threshold of 8. And so that's where we built the predictive model. And I'll just show you one slide on the model. We're happy to share the details of this. If as with most models, it's kind of hard to build a model into an EHR because you have to manage missing data and a few other things like that. So many of the groups that are actually working on this are just working on sort of the rules of thumb. But what we have happening here is the patients whose baseline A1C is 5.5 to 6.9, you can see that we're able to find 10% in that 77,000 patients who make up 33.6% of the ones who are actually going to be out of control. And then the next 10% make up another 20% of the ones who will be out of control at follow-up. So basically you can look at 20% of your patients that you think are safe, and you will have touched more than half of the ones who will have slipped out of control absent any intervention. The factors that are in the model, it's the patients who are below age 65. We used some age categories. People who are fairly far along in their disease, their type 2 diabetes, because they've either got insulin or second-line agents at baseline. If they have some microvascular complications, these are all factors that place them at higher risk. And as I said, we're happy to share the details of the model, but just knowing which factors to look for, the things that distinguish the people who appear safe but are at risk of slipping out of control from the people who appear safe but are at much lower risk of slipping out of control, that's kind of the value of having those factors as rules of thumb. So now we'll switch to the much more colorful metaphor of the leaky boat.
If you have any questions for him, please ask. I mean, we've got all kinds of time. So anybody want to ask anything yet, or do you want to just wait? Well, the first thing I got to say is I come up with an idea about a leaky something, but he comes up with evidence. So which one of us are you going to believe? The nice thing is that the idea and the evidence fit together. And what I'm going to really do is sort of pick up where he's leaving off, because we have a couple of years more of experience of saying, okay, well, what if you did something with that group? And that's what I think I can contribute. But that was excellent. Okay, so yes, so I love working with Hawaii. I mean, how can you not like working with Hawaii? I love to visit them, but even when you don't visit them, they have this spirit. They're kind, they're polite, and so at the beginning of every year, we get all the regions together and say, okay, what are you going to do to improve diabetes control this year? And so we brought Hawaii up, and Hawaii came up with this very nice program with care managers and teams and all kinds of really good stuff. I said, that's wonderful. So we go to the end of the year and we look at the HEDIS report, and they've moved 2%. Well, I want to be kind of gentle and kind. I said, what happened? Come on. I thought you had a really great program. Why didn't it work? And they said very politely, sir, it worked. we got 24% of the people that were over 8 under 8. And I said, well, what happened? Well, oh, I'm sorry. We'll come to this at the end. We'll see if you listen carefully. So they said, well, what happened? Well, 22% went up from under 8. So that was the aha. Yes, they worked. They worked hard. They accomplished something. And guess what? And so we came up with the same thing coming from 2 different parts of the country, totally separate. So that adds credibility to what you said, I think. So let's go on. So the question then is, okay, so what can you do? Okay, well, so you now know you've got some people that are coming up. And you just saw that there's a way to predict who's coming up. And this is one thing we did fairly carefully. We did predictive analytics. And we have a department that works under Michael Cantor, who talked to you a little while ago. And they did a really good job. And so I'm going to give you just the punchline. It turns out that if you look at those folks that are just a 7.8 and a 7.9, and you just focused on those and did some prevention or just follow them, at 22%, or about 20% gave you a 39, or about 40% of the people that were going to go above. But the predictive analytics then looked at 70 different items, including was the last test higher than prior, was it long ago, et cetera, et cetera. And when you put the whole thing together, for just about a third, 32%, they could get just about 60%. So we said, okay, and you could choose whichever you want. If you don't have predictive analytics, you can go with those last 2, and you can do something, and you'll get some response. We went with the second group, and so we got some results. Well, first of all, Hawaii, and so the Hawaii looked at this leaky boat thing and said, we're going to go after those under 8 and see if we can prevent them. And they did that for 3 years. I know this is really, good. And this is really jumpy, but this is what the data really are. Those in red are the ones that went up, and those in green these are the ones that were under and went up. In the green were the ones that were above and went down. And what you'll see is they did focus and they did cut the peaks, but they probably didn't make a big difference because they also, you'll notice, the greens went down a little bit. And why is that? Because they didn't add any new resources. So number one, if you don't pay attention, they are going to go up. If you do pay attention, but you don't add any new resources, you steal from Peter to pay Paul, you may be getting a little benefit, but I think you may have to actually add some resources. That's what this is showing. Or you have to do something different. And I think that's true. And they know it, and they're going to work on it this coming year. The second group was Southern California, the one that did that fancy predictive analytics thing. And what they did, they did 5 things to improve A1C control this last year. And our internal data is that they made a very significant benefit. So that's good. It was not adding any people, which is good. I think the biggest thing was adding accountability, and I'm going to come back to that in just a minute. But basically, they predicted that 20% would go over the threshold, and with their control, with the focusing on those that were under 7, but in that group, that 32%, then they actually got only 12.3% that went up. So they feel that indeed they did decrease the above 8 this year, and I think they did. Our internal data show it. We'll wait for Hedis to give us. The other thing they also mentioned is without a specific focus on these patients, we would have likely seen the 20% increase. So we think that it's a real factor. We both found it. That indeed you can predict who's going to come up using any method. And if you do something that actually makes a difference in those people without taking the resources from someplace else that would neutralize it, that you can make a difference. And I think this is actually a big deal for the United States. You know that since 2004, we have 40 new therapies approved and 0 benefit in A1C of the population. People haven't figured out what's going on. And I will say, I really like technology. We just put 3,000 people on remote glucose monitoring. When they stick the finger, the result ends up in the chart in about 2 minutes. And we are working on that. We don't have results yet. We've got a start, and I like it. But I can tell you what I think is the real key. And it comes back from some great work that was done by Joe Selby, who was a researcher in our group and went on to be head of PCORI. And he looked at these people that weren't improving. And it just a very simple chart review thing. 50% of the charts showed no evidence of treatment intensification, no titration, no initiation, no adherence, nothing. So basically, what was going on is no one was holding the provider accountable for treating the patients. And as I said, Southern California did several things, but the first thing they did is they started moving people into accountability. Our Georgia group went from very badly controlled to very uncontrolled by just holding the physicians accountable. We do have to hold the patients accountable too, but this was just physicians, and it had a major effect. So I think the question is, how do you hold them accountable? Pharmacists, you don't have to hold accountable. That's their job, right? They do it innately. But a lot of other people don't, and they may focus on a lot of different things. You gotta focus on every patient treating with intensification at every opportunity. So anyway, I think that's my soapbox, and let's take questions. John? And there's another microphone here, yes.
Yeah, I'll ask a quick question. Being an insider, John, and maybe Jim, if you want to comment, on the intersection between weight change and change in A1C, what you're seeing in the data there.
We did actually follow the patients who improved, and we found that that was the most powerful factor. A weight change of just 5% was the most powerful predictor of people who were out of control coming into control.
Yeah, diet works.
Yeah, that kind of echoes.
Well, of course, the studies tend to look at a 5% or a 10% weight change, and we found that most of the effect was achieved, controlling for all of the other factors that we put into the model. Most of the effect was achieved by just a 5% reduction in weight.
So it's really important message because it doesn't seem as intimidating.
Right. Very good point.
Well,
Jeff?
actually, that is intriguing because for somebody that used to treat obesity as a problem, it's very common for people that are overweight to gain weight and lose weight, and gain weight and lose weight. And so that pattern then would have a group of patients who would tend to yo-yo in and out of control. So it's important, but you have to perceive it that way as well.
Good point.
The drivers, okay. Jim, you mentioned the failure to intensify treatment, which I think is actually one of the key reasons that pharmacists get such good results, not just in diabetes, but also in hypertension, is that the physicians tend to let people go. You know, they say, why didn't you, why didn't you follow your diet? Why didn't you exercise? And the patients say, well, I couldn't, but I'm going to do better next time, doc. And the doctors will say, okay, come back and, I want you to do that, but chances are it's not going to happen. So that's the failure to intensify treatment. And, everybody wants to believe the patients, and the patients want to believe it too. But, sometimes it doesn't happen. Another factor is the nature of type 2 diabetes as opposed to type 1 diabetes, which tends to go over a cliff and, and that's it. Type 2 diabetes is a long-term progressive decline in function, which inevitably, in many cases, results in insulinopenia, and most of the oral agents, require you to produce some insulin or they don't work. And so it's almost inevitable that at some point, after enough years of type 2 diabetes, a large number of patients just won't have enough insulin to make any of the oral agents work, and that's an issue. But there are many of those factors that are kind of modifiable. The one that I was intrigued by is depression, and depression is very common and frequently undertreated. Did you show any evidence that when depression was addressed that it improved the diabetes control? And is that something that, is an effective strategy?
We haven't studied that question particularly, so it's a good one for a follow-up.
But there is good literature, a very, very good study by Keaton, I believe, in New England Journal of Medicine, December, January issue several years ago, where he brought a goodly number of patients. By the way, these were Kaiser patients, Kaiser nurses, and they were actually on the ALL protocol. So we know something about this group. And what he did is he brought them in, and what they really did was they focused to be sure that the practitioner was accountable for intensifying treatments for the depression. Every month they had to do something, and they had to report it. And they ended up, after 2 years, with the people being on an average of 2 pills, and their depression was better. And once the depression was better, they attended to these very simple metformin, glipizide, NPH standard algorithm that didn't work before. So there is good evidence that if you do the depression first, come back.
Yeah, my experience in treating patients was that unless you address their depression, they couldn't follow any regimen. They just couldn't do it.
That's right.
And also they didn't have the desire to go out and exercise or do anything else. And so you were bound to fail unless you address that first.
And we have a couple of diabetes experts over here. Any comments about that?
Yeah, we did one of our clinics did a quality improvement around diabetes and depression, and treated depression first, and then after that,
Yeah. So that's a really great point you brought up, and I think there is a solution to that one. Other questions?
Yeah, I've got one
yeah,
back
here's
here.
another comment.
You might be right that there's a diabetes distress scale that is published, and so clinical depression may be depressive disorder. There's one because of the diabetes distress, which is a little bit different model. It's not as studied in the same way, but it's also thought to be similarly impactful. If you address that diabetes distress, you do have improvement in clinical.
So, a question back here. I find it very attractive to think that this issue is amenable to, care model process innovation, particularly addressing clinical inertia. But I'm also struck by the data that Dr. Cuddeback presented, showing that actually there's very little variation in this phenomenon across a large group of large cohort of groups, which makes me wonder whether, in fact, it is related to care process, because I'm assuming there's some variation across those AMGA groups. And so I'm just wondering if you could maybe comment on whether you've done anything to kind of try to understand, how care model process or some of these other kind of care process innovations is affecting this phenomenon, or what that data suggests in terms of whether there may be other things we need to look at in terms of influencing this issue.
Well, what we're looking at right now as part of our campaign research for Together to Goal is the question of clinical inertia, the question of is treatment being intensified and how rapidly is that happening, and what's different about the patients where it is intensified. But We're still in process on that, but that's what we're looking at.
In Hawaii and Southern Cal, thank you for the question, because they haven't looked at that yet. But we can now go back and ask them what they found, and so that's helpful.
No, very good point.
I'd like just to add, one more question there, and then I want to ask the audience this thing about accountability, because I'm curious. We've got a lot of real experts in here, and I have this feeling that holding physicians accountable is a big deal, but I'm not sure. So go ahead.
Jim, this is Chloe Bird. I'm at RAND.
Yes,
and
Chloe.
I'm wondering if you've done any like latent class analysis and looked at data over a longer time frame. Because what I see when I look at those patterns is not a group of people who did well, some of whom fall off the cliff, and a group of people who are doing poorly, some of whom improve, but it's just going up and down, like CHF, like all of kinds of other things. And if we artificially divide them into two groups, one group's about to go down, one group's going to have some people who are about to go up. I know that there's recent work looking at what happens when we, instead of focusing on patients having the information about hemoglobin A1C, we focus on patients having some more consistent data on their blood sugars, and that patients can get better. But can you say a little bit more about the patterns and what's working?
Yeah, we really don't have any look of the patterns in these people, and you can see we do have 3 years in one region, 1 year in the other. I think that's an excellent question and something we should look at. What I do think we're finding, though, is that the issues are if we do treat them, and like we have one physician who actually every time an A1C came in, he pulled out where they were they on metformin, glipizide, NPH. He didn't do any type 1s, just all of the type 2s, but that's 90%. And all he did was take the next step. And over a period of 5 years, he was in the 99th percentile of 1,602 practitioners. He was 1,601. There was only one practitioner better. And so it wasn't that the patients were bouncing. And what he would do, though, is every time they came in and the repeat came in coming off, he said, go with another half of metformin or what's your adherence. And all he did were those very simple things. He never used any of the new meds, but he was persistent to do every patient. So I would be very cautious about saying, it's inevitable, they're going to bounce. Weight seems to bounce a lot, but maybe even that you could deal with. Yeah.
Well, I'm not saying that it's inevitable they bounce, but that you may have subsets of people. You may be able
Yeah.
to see. There's some people who it's staying well, and I like that particular clinical approach because it's saying every drop
Yeah.
is an action point.
That's
and
right.
so we're going to stop the cycle.
Exactly. And in Northern California, every patient, every A1C that comes in above criteria, the central diabetes program, I just heard we're out of time. I'm going to finish the sentence. The central diabetes program, I'll talk fast. Central diabetes program sends to the practitioner, and they all have an accountable assigned practitioner. Did you intensify? Interestingly enough, coming back, they only intensified 50%, but that was enough to give them another 4% A1C improvement, and they were already in the 90th percentile. Thank you. I'm going to stop.